All right, so we're going to be covering patient assessment today. And let me get up on the screen. All right, there we go. So this is a very, very long, what am I trying to say? Long chapter. Okay, like I said, edited down. There's still over 350 slides. We're not going to cover each and every one of those. We're just briefly going to talk through this. All right, so when we talk about scene size up, there's 5 things that we immediately need to do. The first one being BSI. Okay, so we knock out BSI, and then there's 4 other things that we need to knock off right in a row. Boom, 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 boom. What are those 4 things? Scene safety. Okay, that's one. What's another one? All right, additional resources. Okay, 2 more. Okay, the number of patients. Okay, number of patients present. And MOI versus NOI. All right, what's MOI? MOI is that mechanism of injury. NOI being nature of illness. Okay, so for EMT school, while we're talking about school here, and for your NREMT testing, when we come to the psychomotor skills, they will be clear-cut and definitive. You will only have a medical patient and an only trauma patient. But in the real world, those things overlap quite a bit. For example, you have, let's say, an elderly individual, man or woman, doesn't matter, and they are diabetic. If they have a diabetic emergency in the middle of the night, they may go unconscious and fall. So now we have not only a medical problem, but we have a trauma issue. Because a lot of elderly individuals, when they fall, they tend to strike their heads more often than not. But we also get that arm out. Okay, that arm out, and they land on their hand. What is that injury called? Does anybody know? When they try to brace themselves and they stick their hand straight out. It's called a FOOSH, F-O-O-S-H, fall on outstretched hand, a FOOSH injury. You're gonna see a lot of those when you guys start doing your write-outs, because you're gonna be going to the nursing homes, especially those of you that are in the fire academy. You guys are gonna get called out to these nursing homes all the time for lift assists, and you're gonna see a lot of FOOSH injuries. All right, so those 5 things we gotta do: BSI, scene safety, number of patients, MOI, NOI, and then additional resources needed. Okay, some of those additional resources are going to be police, like you mentioned, ALS, additional EMS. Okay, possibly you might have a bunch of BLS patients, but it's more than you can handle, so you need more ambulances on the way. Maybe you need fire. You might also need other resources such as electric, especially if they were to crash into a telephone pole, electric pole, or something along that nature. All right, so these 5 things, make sure you know these inside and out, because especially in your assessment, you have to spit out these 5 things immediately. Boom, 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 boom. All right, talking about our primary assessment. All right, so the very first thing that we do is we're going to determine any life threats. All right, so we're going to differentiate between trauma and medical here. When we talk about trauma, we're going to talk about HABCs. What are the ABCs real quick? What is the ABCs? Airway is one. What's next? When we're talking about B, airway, breathing, someone got it, and circulation. ABCs, airway, breathing, circulation. All right, but in traumatic injuries, we have HABCs. Now, you might hear a lot of other different acronyms. There's like MARCH and all those out there. But HABCs is probably the easiest way to do it when we're talking about managing life threats of traumatic injuries. H standing for hemorrhage. And so this is the order in which our patients will die from their specific conditions. If they have a massive hemorrhage, we have to go ahead and treat that before we get into their airway, before we worry about their breathing, before we worry about their circulation. Okay, so determining the nature of the problem, okay, that's the chief complaint. So if we are responding to somebody that's having difficulty breathing, what's our chief complaint? Difficulty breathing. Okay, super easy, super easy. Okay, but we still do managing any life threats, and then ABCs, okay, or HABCs, depending on if they are a traumatic injury or not. So here we're talking about our primary assessment. When we talk about this, so the level of consciousness. So a good way to remember this, after you knock out those first 5 things, okay, BSI, number of patients, scene safety, etc., okay, LOC, ABC. LOC standing for level of consciousness. Level of consciousness. You're probably going to have a test question that talks about what are the varying levels of consciousness. AVPU, AVPU. Have you guys heard that term before? What is, Joshan, what does AVPU stand for? What's the A? Alert and oriented. Okay, alert and oriented. Just because they're alert doesn't mean they're oriented. When we talk about oriented, we talk about, are they oriented to person, place, thing, and time? Do they know where they are? Do they know why they are where they are? Do they know who they are? So some easy questions you can ask is, where are you right now? Who's the president of the United States? What day is it? They can't answer that. What month is it? They can't answer that. What was the closest holiday? Okay, trying to ask them questions. And then you can always ask some additional questions like, if I have 4 quarters and a dime, how much money do I have? How much? Yeah, $1.10, okay? If someone is disoriented, they're going to have extreme difficulties answering that basic math question. So that's one thing you can do. LOC, ABC. So assessing their level of consciousness, the AVPU, AVPU, we talked about A, now is verbal. Verbal, they're responsive to verbal stimuli. If I'm talking to the patient and they open up their eyes and look at me, but the second I stop talking, they close their eyes and kind of shut down, they're only responsive to verbal stimuli. What is P in AVPU? So what?
Physical alert, like whenever you cause pain.
There you go, pain. They respond to painful stimuli. Okay, so there's several ways that we can assess that. And I'm kind of getting ahead of myself here because you're going to see some of this again. There's several ways that we can assess that. In your book, they talk about palpating or tapping around the eye. Okay, tapping around the eye. You can also pinch their traps. Taking your thumb and forefinger, squeezing in between the webbing of their index and forefinger, squeezing that point. And they're also going to talk about a sternal rub. So this is Sean talking, not the book talking, but I'm not a fan of the sternal rub. If someone gets into a car accident and they're an unrestrained driver, what does that mean first and foremost? Unrestrained. No seatbelt. What's the first thing they're going to hit? The steering wheel. Okay? What are they hitting the steering wheel with? Their chest. All right, so if I arrive on scene, there was a major car accident of an unrestrained driver, and they are unconscious or appear to be unconscious, unresponsive, and they struck their chest against their steering column, and I go ahead and rake across their sternum, I might cause additional injury to that patient. So that's a Sean thing. I don't like that. Just squeeze their traps. Okay? The likelihood of you causing any additional damage or injury to them, very, very, very small. Okay? And then the U in AVPU, I already talked about this, unconscious or unresponsive. Okay, so make sure you know the AVPU because you're probably going to see a test question on one of those. It's probably going to be like, what does the P in AVPU stand for? Okay, and it's responsive to what type of stimuli? Painful stimuli. There you go. So LOC, ABCs, and patient priorities. Okay, are they a load and go or stay and play? What does that mean? So if they're a load and go, that means that they are an emergent patient that we need to get out of there ASAP. We need to be on our way to the hospital, treating them as much as we can as EMTs, and notifying the hospital of what is inbound. All right, so any life-threatening condition that we find in the primary assessment, we need to treat before we move on to the next portion. All right, so here's a little algorithm that we're going to ignore here. Developing a general impression is really important. We're going to see a photo later that's going to really drive home what we're talking about when we form a general impression. Okay, determine the chief complaint and observe the environment. So when we're talking about observing the environment, this is a part of our assessment before when we're talking about scene safety, but it's also about the patients and what is going on with their condition. So if I arrive to a scene where someone is having difficulty breathing and I walk in the house and I see black mold all over the walls, could that be a correlation? Yes, absolutely. So I'm going to observe the environment and see if there's anything that's tying what I see to what the patient is complaining about. All right, so here we're talking about trauma. Okay, so identify and control any major bleeding and manage other life threats. You're probably going to see some questions about tourniquets. Okay, when we talk about this. So if I arrive on scene of, let's say, a motor vehicle accident, and I see somebody bleeding heavily from their lower left extremity, their lower left leg, where do I place that tourniquet? Nailed it. High as I can on the affected extremity. High and tight. High and tight. Okay? How do I know when I've tightened it enough? There's either no pulse, okay, that's a definitive answer, or if I don't have their clothes off yet because I just arrive on scene and I see they're bleeding and I throw the tourniquet on, if they're no longer bleeding from that extremity. Okay? So no pulse is definitively how we determine, but if they're no longer bleeding out, okay, that's another way that we can determine it while we carry on with our assessment. Because are we going to stop what we're doing and check their pulse when they might not have an airway or might not be breathing? No. Okay, time is of the essence, so we have to do that HABC in traumatic patients quickly and thoroughly. All right, so here's what I was talking about when we talk about general impression. So general impression of this woman, she looks very pale, right? So just looking at her, she's sick. That's obvious. I can tell that this person is very sick. All right, but she came to the door. We knock. Hello, EMS. She arrives. So just a cursory example of assessing their mental status. What do you think hers is? Probably alert. Okay? If she was able to get up, come to the door, answer the door. All right, likely she is alert. All right, this individual, we talk about general impression. What do we see with this guy? Probably having difficulty breathing because he's in what type of position? What do we call this? Starts with a T. We call it tripoding, okay? Tripoding. All right, he's got his hands on his knees and he's leaning forward. He's also pursing his lips, okay? That's also another sign of someone that's having difficulty breathing. What do we see on the table right next to him? A meter dose inhaler, okay? And another one. This guy is bleeding. And real quick, when we're talking about bleeding, the different types of bleeding, when we're talking about venous or capillary, or excuse me, venous or arterial, what's the big difference there? Arterial bleeding is what kind of color? Bright red, dark red? Arterial bleeding. Bright red. Why is it bright red? Because it's oxygenated blood, okay? We also, book answer, we're going to see spurting, okay? You're going to see spurting. All right, here's a good question for you. So let's say that we have somebody that, this guy, okay? When we arrive on scene, his partner or his coworker tells you that he injured himself and initially there was bright red blood spurting all over the place. But you arrived about 5 minutes later and we no longer see that bright red bleeding. We no longer see that spurting. What does that tell us about the patient? Say what? He is running out of blood, okay? Because we no longer have enough blood in our body for that pressure to cause that spurting. So is that an emergency? Absolutely. This is already an emergency, but the fact that it was spurting initially and now is not amps that up significantly. How would you treat this? Tourniquet where? High and tight every time. All right, this individual. So possibly unresponsive. So we're talking about that medical versus trauma. We can't rule anything out. Okay, we're going to have to do a very thorough assessment of our patient. All right, so what is one possibility that happened to this guy? What might have happened to him? He might have just fallen out of bed, okay? Maybe just fell, hit his head on the dresser, and maybe it's solely trauma. What's a possible medical condition? Heart attack, diabetes, seizure, possible asthma attack, so where he could no longer breathe and he just collapses. All right, there's a lot of different things that could be going on with this guy, and we're gonna have to rule them out one at a time. So, how do we approach this? ABC or HABC with this guy? So what? HABC, okay, because we can't rule out any type of trauma. We don't know if there's blood or anything underneath him, all right? So we got to be very thorough in that quick visual blood sweep. Another thing that we do in those first few moments is our possible spinal restriction, okay, spine motion restriction. If and here's just a little tidbit for your national registry. If you see anything about immobilization, spinal immobilization, the answer is already wrong. We cannot immobilize entirely. We can only restrict movement. Because when you guys have had your head in that C-collar, could you still move around? Yes, you can still move around. So it is restricted. It is not completely immobilized. Would you put this guy in a C-collar? Maybe? Okay, unknown. All right, so what if he had a goose egg on the left side of his head? Yeah, okay. We can't see the left side of his head from here. All we can see is the right side. But if we're doing our assessment, boom, we look and we see a large goose egg. That means that he probably hit something on the way down. And if, excuse me, I need some water. And if it was that significant to cause that much of an injury, there's a possibility that he has some cervical involvement. All right, so talking about additional environments that are difficult to assess our patients in. All right, so this is just someone that's outdoors, outside, and possibly, I don't think they're homeless, but maybe, we don't know. All right, so the environment outside can make it difficult when assessing our patients. All right, talking about this, we're talking about patient's condition and assessments here. So they have a 12 lead on. What's something you notice about this patient? Nailed it. How do we know that he's had heart surgery in the past? He has a large scar down the very center of his chest. So that's for a bypass surgery. All right, determine if the patient is injured or ill, the MOI versus NOI. And then when we talk about a mechanism of injury, we're going to talk about penetrating trauma versus blunt trauma. Both of these types of injuries create different challenges when it comes to treating them. All right, for penetrating trauma, it's a lot easier to see what's going on because they're bleeding from it. Okay, they're bleeding from it. They may not bleed much, but they're going to bleed some. Blunt force trauma has its own difficulties because if, let's say, someone was struck in the stomach with a bat, how long is it going to take before bruising becomes evident? Minutes, you know, who knows? Could be 5, could be 10, could be 20. It could be an hour. We don't know exactly how much time. All we're going to have to go off of is what the patient is complaining about. Or if we're doing our assessment when we're palpating the abdomen, if they show signs of tenderness, or if there's any abdominal rigidity or distension or anything like that when we're doing our assessment. And we're going to go over decap BTLS here in a second. All right, so this guy, he has some type of abdominal injury, okay? So I may be mixing up paramedic and EMT here, but how would you go about treating that type of injury? Have you guys gotten to your trauma section yet? No, yet. Okay, disregard that. Okay, so talking about general impression, we're still just coming in, doing our doorway exam. What do we see going on with this guy? He's lying in bed. He's kind of staring off into the distance, right? All right, so 2 people came and entered his room, and he's not focusing on them. So immediately offhand, would you say he's alert and oriented? Probably not. All right, he might be like, all right, Mr. Johnson, Mr. Smith, or whatever. and then he starts to look at you and track you, but only when you start talking. What would we say he is on the AVPU scale? Elicit verbal stimuli, exactly. All right, I'm turning to chief complaint. Hello, sir, ma'am. Who called 911 and why did you call 911 today? Really, that's it. If they're unable to speak, observable trauma, okay, that's going to be the chief complaint, or whatever the call was coming out. So motor vehicle accident could be the chief complaint if it's just a train wreck of a patient where they have several injuries. Life-threatening injuries. Okay, so these are going to be some big things that we have to treat immediately, but we're still working on that HABC order. Okay, the HABC order. So major bleeding, that's going to be hemorrhaging. We're going to take care of that, whether it's a steady flow or spurting. Steady flow, what is most likely that from? Arterial or venous? Venous. And we talked about arterial blood was spurting and bright red. What is venous blood like? It is darker. Okay, it's much darker because it is non-oxygenated blood. All right, airway compromise, whether it's teeth, blood, vomit, secretions, anything like that, foreign objects in the airway. How do we treat this? Say what? We're going to have to suction. Okay, we're going to have to suction it out. All right, here's a question. You're called out to Cameron Park. You're called out to Cameron Park. And you have to walk about, let's say, 500 meters into the woods off the trail, and you're unable to get your ambulance back there. You have the option of bringing which one of these things can you absolutely not fail to bring? An O2 tank, suction apparatus, long spine board, C-collar. All right, I hear suction. Any other answers? Spine board? Any other answers? I think I heard somebody say C-collar at some point. So when we're talking about HABCs, which one of those is going to clear our work through that HABCs? Suction. Okay. You have to bring your suction apparatus with you. You might see that later. All right, obvious wounds to the chest, obvious open wounds to the chest. All right, we're going to get into a trauma section where we're going to talk about how to treat those. But I don't think you're going to see any questions on it, but it's called an occlusive dressing, and you're going to get this in your trauma lecture. Occlusive dressings, those are dressings that are made of plastic. The air cannot pass through. Typically, they're made of plastic. Air cannot pass through it. Why is it so important that we have something the air cannot pass through when we have an open wound on the chest? Yes. Okay. We don't want air coming in or out, and we're based on a negative pressure system with breathing. All right. So we want to go ahead and close that up to go ahead and recreate that negative pressure system. Paradoxical movement. We're going to talk about this more in trauma. We're going to hear about the term a flailed chest, but we don't need to talk about it now. If they are unresponsive with no breathing and no normal breathing, agonal, gasping breaths. All right, so if they are not breathing, what's the next thing we check? Pulse, circulation, exactly. They're not breathing, we're checking pulse. And if they're not breathing and there's no pulse, what do we do? CPR. Nailed it. Immediately start chest compressions. All right, identifying life threats. We just talked about this briefly. Cardiac arrest must be recognized immediately. Begin chest compressions, provide airway and ventilation, and apply an AED. When it says open the airway and provide ventilation, what's another thing we should do with that airway? How are we going to secure it? Either an OPA, an NPA, or a supraglottic airway. So we need to secure that airway. That should be one of the top priorities as well. Just because we're ventilating, that may not be enough. All right. Oh, what if they start throwing up? So you're gonna have to check their gag reflex first and foremost, and you can do that really quickly with an OPA. But that's why you got to have that suction apparatus on hand. If the tube's already placed,
Yeah, can you still throw up with it or no? Like,
okay, kind of. They can throw up around it, so they could still be vomit in the mouth. But hopefully that is sealing that to prevent any air from escaping around it or through it. So ideally, that should not happen. But that's also why we have to ensure we have proper placement of our supraglottic airways.
so if you had like a spinal patient or whatever, like if they had a C-collar on, but you're trying not to move the back of the neck at all, and they start throwing up, would you just suction or would you try to turn?
You turn them as a unit, so you got to move their whole body to the side. But also, okay, so now we're getting into some what ifs, some pretty out there stuff. So the question, because others may not be able to hear this, was that if someone has a C-collar on, there's a possible spinal compromise, and they start throwing up, what do we do? So we remove them as a unit, but also, like we're saying, what if it's in the middle of CPR? Like, well, we have to save their life first and foremost. So we're going to do what we have to do to secure their airway, suction their airway if necessary, and then start CPR. If that means that there is some involvement or movement that may not be perfectly in line with trying to maximize the safety and security of their spine, you want to save their life first and foremost. For another example of this is, let's say we arrive on scene and they are in a vehicle and the vehicle catches on fire, and we suspect spinal involvement. What do? We just yank them out, okay? Are we going to take time to put them in a KED and pull them out that way? No. The vehicle's on fire. We now have a possible endangerment for our patients, so we got to get them out of that situation. So that's one of those cases where, yes, we want to do everything in our power to not cause any further harm or injury to the patient, but if the alternative is certain death, we do what we have to do to save their life. Life above all else. All right, spine motion restriction, not immobilization. All right, so we know how to do this. We've already gone through this. We know exactly what we're doing when it comes to restricting their spine and putting them on this long spine board. So we're going to get through all this. All right, AVPU, AVPU, we just talked about this. Make sure you know this. I cannot stress this enough. You're probably going to see a test question about one of these. It's probably going to be something like, what does the P in AVPU stand for? What does the V in AVPU stand for? All right, responsive verbal stimuli, painful stimuli. All right, we talked about this. Here's some of the places that we discussed earlier. Trapezius or armpit pinch. Okay, supraorbital pressure. Okay, around the eye. Sternal rub, which I do not like. I'm not a fan of. Nail bed pressure. What is that? So the easiest way is take your pen, which you should always have on you, and just press that against their nail bed. You can do it to your buddy real quick, and you can see how quickly you get their attention. Okay? Or pinch the webbing between their thumb and index finger. Like I said earlier, you can squeeze there. It's a pressure point. Here's an example. Trapezius pinch, supraorbital pressure, sternal rub, which I said I don't like, earlobe pinch, and we're moving on to assessing level of consciousness. All right, so we're still talking about this. This is going to be less important now, but more important later when we're talking about trauma and other types of injuries that we might see. When we talk about flexion or extension posturing, you might see a question about this. Okay. These two that we're going to see, decorticate and decerebrate posturing. Okay, so decorticate. The patient is going to curl into themselves. We're going to see them curling into their core, i.e. decorticate posturing, curling into their core. Their feet are going to start pointing inward towards each other. Bless you. Their hands and arms are going to curl in towards their body, okay? And we will see their head tuck in towards their chest. Decorticate posturing, and then decerebrate posturing. we're going to see the opposite. Instead of coming in towards the core, they're going to start to go like this. And we're going to see their hands go outward, their legs going outward, and their head is going to go up and away. What type of injury is going on with this individual? Brain. Okay. This is a major problem with their brain. We have a lot of swelling of the brain. And where can the brain go? There's only one place the brain can go, and that is at the base of the skull, the hole in the base of the skull, called the foramen magnum, okay? Because that's where your spinal cord and column link up to the brain. Okay, that's the only place, because other than that, the brain is trapped in the cranial vault, has nowhere to go, so it can only go down once it starts to swell. And if you see this type of posturing of your patient, this decorticate or decerebrate posturing, they are they're going down the drain. Okay, they do not have long for this world. Okay, you need to get them to the hospital immediately. If you came on scene and you saw this, this is an immediate load and go. Okay, you're throwing them on the back of the truck and you're trying to get them to the hospital as quickly as possible. So why is this important? Knowing what this is, this flexion versus extension. Okay, so flexing, you're going in, extension away. Okay, because when we talk about the Glasgow Coma Scale, if we see a normal flexion or extension, this is when we're talking about motor response. So most of our patients are going to be here. They're going to be in the 5, 6, 4, or 1. We rarely see the 3 and 2. When we talk about that abnormal flexion and extension, we're talking about decerebrate, or excuse me, decorticate and flexion and decerebrate and extension. So which one's worse? If an abnormal flexion is a 3, and that's, yeah, somebody said it, extension. Which one is that? Decorticate posturing or decerebrate posturing? Decerebrate posturing is extension. That is the worst of the two. So your Glasgow Coma Scale, I cannot spit this off at any given time, but for your write-outs and basically anywhere you go, most hospitals are going to ask about what is their GCS. And you should be able to know it. So make sure that you have like a little cheat sheet. Or another recommendation is a badge buddy. So all of you have badges, okay? What you can do is on Amazon, or you can make it yourself. I could not care less. But on Amazon, they have like an EMS badge buddy, and they have it's like a pack of like 20 or so. And in there is that Glasgow Coma Scale. Okay, that's what I carry around because I can't remember this at the drop of a hat. I have other things to think about. All right, level of consciousness. All right, we talked about this before when we're talking about level of consciousness and the level of responsiveness. So we're talking about that verbal, painful, and unresponsive. All right, problems with some types of painful stimuli. We're always going to assess a central painful stimulus, okay? Okay, because peripheral stimuli may reach the spinal cord, but not the brain. All right, so what can we do? We can do that trapezius pinch. We can do the supraorbital poking and prodding around the eye. And then the U of AVPU, unresponsiveness. If they do not respond to verbal or painful stimuli, they are unresponsive, okay? Unresponsive. Unresponsiveness to verbal or painful stimuli can indicate the patient's inability to maintain his or her airway. If we're worried about their airway, what do we do? Say what? Okay? We're just airway. They're unconscious, unable to maintain it. What do we do? Open it up and what do we put in it? Okay. We're gonna start, with the basics and then move on up if we have to. But we can do an OPA, MPA, and then if necessary, move on to that supraglottic airway. I don't think it's been mentioned here in the slides yet, but when we're talking about opening up the patient's airway, if they are a traumatic patient, how do we open up the airway? Head tilt, chin lift, or jaw thrust? No. In traumatic patients, jaw thrust. Okay? Jaw thrust in traumatic patients. Probably going to see that again. So, why not a head tilt, chin lift for our traumatic patients? Because they might have some of spinal compromise. In that head tilt, chin lift, we are manipulating the spine. In a jaw thrust, we're placing our fingers, okay, our thumbs directly beneath the mandible, okay, that's what this part of the jaw is called, and we're pushing forward. Okay, pushing forward. And that's going to open up the patient's airway. Is that something we can maintain indefinitely? No. So we'd have to put in some type of oral or nasal adjunct. All right, okay, documentation. It's always going to be important. Okay, now we're getting to that ABCs. We just talked about it a little bit. Determining their airway. Indications for airway compromise include stridor. All right, so have you guys had your breathing lecture yet? Over respiratory issues or anything like that? All right, so stridor is an upper airway condition, upper airway for stridor. Yes, yes, because it's the airway constricting, and there's a lot of reasons that it can constrict. Trauma, okay, smoke inhalation is another one. All right, so stridor, upper airway. You're going to see that again. Difficulty speaking, gasping, or not speaking at all. Okay. In unresponsive or severely altered, you have a high risk of airway compromise, so take action to open or maintain. All right, how do we do that? OPA, NPA, or SGA if necessary. All right, assess the airway. To open the airway of a trauma patient, use the... It's up on screen. Jaw thrust. Okay. Use head tilt chin lift for a medical patient. Trauma, jaw thrust. Medical, chin lift. You're guaranteed to see that again. All right, opening the airway. We have several techniques. Manual airway maneuvers. Those manual airway maneuvers we just discussed. Jaw thrust, chin lift. Okay, suctioning or finger sweeps. Do you ever do a blind finger sweep? No, we never do a blind finger sweep. If we see the obstruction, then we can try to sweep it out with our fingers, okay, but never blindly. Airway adjuncts. We just talked about some of these. Abdominal thrusts, if they are possibly choking. And positioning, okay? Positioning is going to be very similar to what we talked about before. That head tilt, chin lift, okay, jaw thrust, or maybe just sitting them up. Maybe that's going to be more helpful for them. Snoring. Snoring, what is blocking the airway? The tongue. You might see that again. All right, manual maneuvers we just discussed. Airway adjuncts, OPA, NPA. And these are some of the possible sounds you might hear for airway obstructions. I think I added these in. I don't think they're listed on the actual slides. So snoring is a possible one you might hear. Snoring is caused by what? The tongue. Gurgling, okay, so some type of fluid in the airway. What are some fluids that might be in the airway? Water, saliva, what? Vomit or emesis, okay? Blood, okay. Yeah, you're going to see the term emesis a lot. E-M-E-S-I-S, I think, emesis, okay? That is vomit, okay? That is vomit. Crowing, a crow-like sound on inspiration. You might see this in children. Or stridor, a harsh, high-pitched sound on inspiration. Inspiration being what? Inhaling or exhaling? Inhaling. All right, open the airway, suction, and position if needed. Okay, when we're talking about gurgling, crowing, and stridor, these high-pitched inspiratory sounds, okay, manual maneuvers will not relieve the obstruction, okay, because... Well, why won't it? Why won't manual maneuvers relieve the obstruction for something like crowing or stridor? because it's the airway itself. It's not necessarily the positioning. Okay, do not insert anything into the airway of a pediatric patient with crowing or stridor. Okay, that's a big star there. Do not do that. Still talking about these ABCs. Okay, after opening the airway, we're going to determine whether breathing is adequate or inadequate. What is the normal rate for adults? 12 to 20 non-labored. Okay, 12 to 20 non-labored. Let's say they're breathing 14 times a minute, but each and every breath is a struggle for them. Are they breathing adequately? Absolutely not. Okay, determine the need for early oxygen therapy, i.e. possibly a CPAP. Okay, CPAP. So let's talk about that real quick. I had a patient, this is about last year. She had at-home oxygen. And let's talk, and a side note to that. So the at-home oxygen, that tubing, I don't know the math, but for each foot, it decreases the efficacy of the oxygen, the amount that they're actually getting. So if they're at, let's say, 2 liters per minute, but they have a 50-foot tube, they are barely getting any of that 2 liters per minute. Okay, it's not very effective whatsoever. That's just a tangential to this. So this woman, she was having difficulty with her oxygen tank, so she just decided to skip it. She was also on dialysis. What is dialysis for? What organ? Kidneys. Okay, so she was on dialysis. She went for her appointment, and that basically wiped her out. She came home, went to take a nap. She slept face first on her couch. Her friend came over to have their normal afternoon, lunch and whatever they do, talk, gossip, and she was not responsive. We got her there. We were able to get her up, get her on oxygen, but she was just struggling. She was having a very hard time breathing. So what do you think we did for her? Put her on a CPAP. Okay, she was alert and oriented. All right, which is one of the things that's required for the CPAP. She was alert and oriented when we got her up and got her some oxygen, but she was just struggling. She was having such a hard time, so we gave her that CPAP because that was just going to push oxygen into her. Okay, so here's some medical terms you need to know: bradypnea, tachypnea. The right here, the apnea part. What does that mean? Breathing. Brady is what? Slow, tachy, high or fast. Okay. You're going to see, in addition to bradypnea and tachypnea, you're going to see stuff like bradycardic and tachycardic. What does that mean? Slow and fast heart rate. All right. Abnormal respiratory rate, we said it was between 12 and 20. All right, between 12 and 20, non-labored, okay? But technically, outside of that 12 to 20 is either going to be bradypnea or tachypnea. All right, we might have to ventilate our patient. What is this person doing? They're doing the look, listen, and feel, okay? Look, listen, and feel. They are looking at the patient's rise and fall of the chest. They are feeling any breath on their cheek, and they are listening for air escaping the patient, okay? What is this guy doing? On our left. Yeah, he's holding manual C-spine. All right, retractions. Okay, so this is same thing down here. Use of accessory muscles or nasal flaring. Tracheal tugging, which you're not going to be able to see very well as an EMT, and I don't have a good example for you. So go ahead and watch a YouTube video on tracheal tugging. Okay. Pale, cool, clammy skin. What is that a possible sign of? Pale, cool, clammy skin. Lack of circulation. Okay. This is what we see oftentimes. That's kind of like the textbook answer for, oh God, it just left me. Sorry, I'm having a different conversation over here. Shock. Thank you. Shock. If we see pale, cool, clammy skin, shock. What is cyanosis? Bluing of the skin. Okay, we see that in the lips, around the mouth, around the fingernail beds. Okay, In our infants, we might see that over their entire body, their chest, their face, all that. Cyanosis. Make sure you know that term. It means bluing of the skin. Okay, we're talking about look, listen, and feel. Okay, adequate or inadequate respirations. When we are oxygenating our patients, what is the rate we're going to oxygenate our patients at? Not 6 breaths per minute. Okay, that's not enough.
One breath every 6 seconds.
1 breath every 6 seconds. How long is that breath going to take? 1 full second. All right, so look for hypoxia or hypoxemia. What is hypoxemia? What do you think? When we see emia, no sir. Okay, we're still hypo, okay, which means too little. Emia, blood. We're talking about blood here. Okay, so hypoxia versus hypoxemia. So we have too little oxygen in the bloodstream versus we are not perfusing well enough. All right, poor perfusion. Poor perfusion, okay, one of those examples of poor perfusion is, I was just there. Where was it? Cyanosis, pale, cool, clammy skin. Okay, those are examples of poor perfusion. Heart failure, CHF, congestive heart failure. Those patients typically do really well with a CPAP. And respiratory distress can be basically anything along those lines. All right, talking about the C in circulation, that CCT, color, condition, temperature. Color, condition, temperature. Is their color appropriate to their race? Condition, okay, is it hot and dry? Is it cool and clammy? Or is it warm and, I hate to say it, warm and normal? And temperature, oh, we just kind of talked about this a second ago when I said cold and clammy or hot and dry, but color, condition, temperature. So we're checking for the absence or presence of a pulse. Where are we checking for that pulse? On our patient. Okay, we're doing a patient assessment. Where are we checking on that patient for their pulse? What is that pulse point called? It's called the carotid, but that's incorrect. We're going to check the radial artery. The radial artery. Okay, why do you think we're checking the radial artery? Say what? Okay, so if I am checking their radial pulse, okay, and it's present, I know that their carotid is also present. Okay, you cannot have a radial without also having a carotid. So it tells me that both are present. So this person, she's only checking this one side. I would recommend that you check them both simultaneously. Why do you think maybe you should check them both simultaneously? Yes, so they're equal. Okay, pulses are present and equal, especially if they are in some type of motor vehicle accident or any type of trauma. Okay, I want to make sure that there's nothing affecting one extremity that's not affecting the other. So this guy, we know it's a trauma of some sort because he's holding C-spine. So let's say that this arm was broken and she's checking his pulse based off of that broken arm. Could that be a different pulse rate from this arm? From the other arm, his right arm? Yes. So checking them at the same time is ideal because you can check that they are equal. Okay, other ways that we can assess their circulation. Okay, capillary refill. Capillary refill should be less than how many seconds? Less than 2 seconds. What is capillary refill? Pushing down on their nail bed. All right, so it should turn from that pink to white and back again in less than 2 seconds. You might see that on a test question. Infants. Okay, infants less than 1 year old. Where do we check their pulses? The brachial artery. Okay, brachial artery. All right, when checking the pulse, okay, we're not only checking the rate, but we're also checking the rhythm and quality. Okay, rate, rhythm, and quality. So when we say rhythm, what are we talking about there? Yes, is it a constant pace, lub dub, lub dub, lub dub, that we should expect from the heart? Or maybe they have a condition like AFib, atrial fibrillation, where it is irregular pattern, okay, an irregular pattern, a regular rhythm. So rate, rhythm, and quality. Is it strong or is it weak? Okay, is it bounding? Do we have a good, firm, strong pulse, or is it very, very weak and difficult to feel? All right, significant bleeding. This is that HABCs. All right, so this guy, this trauma, how do we say we're going to take care of this? High and tight what? High and tight tourniquet. Okay, additionally, with checking the circulation, this is also that color, condition, temperature. Okay, they're taking the back of their gloved hand and placing that directly on the patient's skin. That's if you can't tell through your gloved hand, which most of the time you'll be able to. Okay, here's some other examples when we're talking about color, condition, temperature. We said cyanotic was what color? The bluing of the skin. Okay, bluing of the skin. Pale or mottled. Okay, mottled is that kind of a combination of like blues, reds, and purples. Okay, it's difficult to show you without a photo, which I'll try to get later. Flushed, red skin. Okay, that's typically a sign of vasodilation, and this is going to be important when we talk about our shock lecture later on. Yellow, know this term, jaundice. Okay, we're not only going to see yellowing of the skin, but you might also see yellowing of the eyes. The whites of your eyes are called your sclera. Okay, and someone that has severe liver failure might be experiencing jaundice. Not only a yellowing of the skin, okay, but a yellowing of the eyes as well. So Hispanic patients, they typically don't turn yellow. They turn very like coppery if they have a type of liver dysfunction. I don't think I've ever ran into African American individuals in liver failure, so I can't really comment on the color of their skin. But I have seen Caucasian and Hispanic individuals. So in Caucasian, it's very much a yellow, very clearly, and in Hispanic individuals, it's more of a copper tone to their skin. All right, so we're talking about temperature, CCT, hot, cool, cold, clammy. Okay, these are all things that you might see, and their condition. All right, is it dry? I hate this term. Or sweaty. Let's just say sweaty instead of moist. You might see the term diaphoretic. Have you guys heard that term before? Diaphoretic or diaphoresis. Okay, this stands for sweating. You're going to see that later. And make sure, and I'm driving these medical terms home because on your exams, now you're going to start seeing a lot more of them. And additionally, on your NREMT, it's going to be very medical terminology heavy. All right, cap refill. How quick does that have to be checked? Within 2 seconds. Okay. For children, okay, you can go ahead and just kind of press down on their kneecap. Okay, that's one way you can do it. Okay, that blanching is another sign of the determination of whether or not they're perfusing well. If it turns white and then quickly turns back to their appropriate skin color. All right, shock. We talked about this earlier. Cooled, clammy skin. Pale, cool, clammy skin. That's going to be a big sign that they are in shock, which is a life-threatening condition. All right, what do we do for somebody that's in shock? Oxygen, okay, well, ABCs, really. Airway, breathing, circulation, and then transport them quickly. Unstable patients are a high priority. If they're in shock, are they stable or unstable? Unstable. All right, unstable patients receive rapid secondary assessment. Okay, that's doing your DCAT BTLS all over again and getting them out of there. All right, so we talked about the ABCs. When we talk about trauma, we said there was the H ABCs. What's the H stand for? Hemorrhaging. Okay, you might see this acronym, MARCH. which is really just massive hemorrhage, airway, respiration or breathing, circulation, and then the H is hypothermia. Okay, hypothermia, keeping the patient warm and dry. You might also see this, okay, X, A, B, C, D, E. Okay, we're just kind of going off the deep end here. Just keep it simple, ABC, H, ABCs. All right, secondary assessment. Secondary assessment performed after the primary assessment is done, all right, and now we're going a lot more thoroughly with our patient, and we're doing that deep head-to-toe assessment. We're going to be checking out their head a lot more thoroughly, all right? We're going to be getting their vital signs. We're going to be doing their patient history. What are the two acronyms we use for patient history? Sample and it's in the alphabet. Starts with O, OPQRST. Okay, we're going to talk about those more in a second. The anatomical approach, okay, that is head to toe. So starting at the patient's head, doing our decap BTLS, going all the way down to their toes, and then assessing their posterior side, okay. We got to check their back as well. Do not forget that. All right, secondary approach, we just talked about this. Okay, we're going to expose our patient, okay, by cutting off their clothing, assessing the head. Okay, I'm not going to go too deeply into this. All right, but this guy, decap BTLS, what do we see? Okay. What part of decap BTLS would you call that? Yeah, definitely a deformity, right? That's abnormal. Okay. We could also say that possibly a contusion. Okay, we don't see a lot of bruising just yet, but that may be the development of what we'd call a goose egg. All right, disjointed gaze. All right, this is abnormal. We might see this, and more importantly, annotated in our secondary exam when we're checking for Pearl. We're checking for Pearl. What does Pearl stand for? PERRL. Is that acronym in this section? I don't even remember. It's important. You need to know it. That is, pupils are equal, round, and reactive to light. Pupils are equal, round, and reactive to light. This is something you absolutely need to know, okay? Pearl, because that I think that's also a test question. I'm not 100% sure. You guys want to take a break? Yeah? Okay. Let's go ahead and Waste time here, you know what I'm saying? Just want this to be beneficial. All right, so talking about the secondary assessment. All right, so we're gonna blaze through this section right here because we're just talking about decap BTLS here. All right, so when we're palpating the skull, we're looking for any abnormalities, especially behind the ears. Okay, behind the ears. What is that bruising called behind the ears? There's a special term for it. What is bruising behind the ears called? Okay, that is called battle signs. Battle signs. You need to know that term. We're probably going to see that again, and you need to know what that is because that's something that happens, unfortunately, very often in head trauma. Okay, so if I look behind the ears and I see bruising behind the ears, one, that's a late sign of a possible skull injury, and it typically means a basilar skull injury. So the base of the skull is probably fractured. Okay. Battle signs, again, battle signs. Know that term. All right, we're also looking in the ear for any blood or fluid coming out. We do not pack it if we see anything coming out like that, okay? We might put a loose dressing over the ear, but we're not going to pack the wound here. We're just going to allow that blood to leak out. Why would we not want to pack that wound? Yeah, it's not supposed to be there in the first place, okay? But we want to allow it to drain out, okay? Because we don't want to create any more additional pressure building up in that tight space, okay? Have you guys heard the term CSF? Okay, CSF, you heard that term. It stands for cerebrospinal fluid. Cerebral spinal fluid. All right, why am I bringing that up? Because if we see blood leaking out of the ear, we need to take like a 2x2 or a 4x4. We need to take some type of gauze dressing, and we need to allow it to catch that blood. Okay? So what we are doing by allowing that gauze to catch that blood, we're going to set that off to the side, and if there is cerebral spinal fluid inside of that blood, it will separate. And it will create what we call a halo effect. So it is kind of a clear-ish. I don't even know how to describe the term. It's almost like a lubricant, but not quite. It's not water. It's kind of like an in between like watered down lubricant. Okay. That's what CSF kind of feels like once you get it on your gloves or anything like that. But anyways, that halo effect, it's kind of a yellowish in color around the outside of the blood, and we call that a halo because it kind of makes a little yellow circle around the blood. So what does that mean? That means that there is a compromise with the spinal cord, and CSF is now leaking out of the body. Problem or not a problem? Major problem. Okay, we have a big problem here. All right, so that's just a really quick test we can do to see if there's any CSF out. Again, we call that the halo test. All right, we're going to check the eyes. What are we checking the eyes for? What did we say that acronym was? PEARL. What does that stand for? Pupils are equal, round, and reactive to light. Pupils are equal, round, and reactive to light. Okay? Looking in the nose, looking in the mouth. Okay, all right. So we get to the neck. All right, looking at the neck. We're looking for JVD, jugular vein distension. Okay, jugular vein distension. You have your carotid artery, but you also have next to it your jugular veins. All right, jugular veins can be a sign of, JVD can be a sign of several different conditions that we're going to go into later, more in depth. But just a couple of them that might be on your test or whatever. A tension pneumothorax, you might see JVD. Congestive heart failure, CHF, you might see JVD. Or a cardiac tamponade, you might see JVD. I don't think you're going to get any of those test questions now, but this is just kind of preparing you for later. All right, palpate for tracheal deviation. Your trachea, okay, can deviate. That means it can actually go to one or the other side instead of sitting in the middle like it's supposed to. That is a late sign of a tension pneumothorax, and we're going to get way more into that when we get into our trauma section. All right, we talked about this. We get to the chest. We're going to inspect for open wounds, look for paradoxical movement. Okay, we talked about a flailed chest segment. Okay, flailed chest. Again, we're going to get more into this in your trauma section, but just FYI, the definition of a flailed segment is two or more ribs that are next to each other, are broken in two or more places. All right, we're going to palpate the chest, and we're going to auscultate breath sounds. Where are we auscultating? What does auscultating mean? Listening. Where are we listening? Apex, apex, base, base. Apex, apex, base, base. Here we are palpating, listening. All right, we get to the abdomen. We're looking for deformities, okay, contusions, all that, okay, decap BTLS. But more specifically, when we're talking about the abdomen, we're talking about distension, okay, rigidity, tenderness, and pulsating masses. So you need to know those. Tenderness, rigidity, distension, and pulsating masses. So you may have seen those commercials back in the day, only you can save a child, as little 34 cents a day. You see some of those children that have been starving for a while, they have that abdominal distension, okay? You see that? They're very, very thin, but their abdomen is sticking out, is distended, okay? Rigidity, pretty self-explanatory, all right? The abdomen is very firm and rigid. What do you think that's a sign of? Say what? No, sir. This is a sign of trauma. Okay, internal hemorrhaging. All right, we may also see with that bruising, but that may not be visible just yet. All right, abdominal trauma like that, bruising, problem or not a problem? Big problem. Is there anything we can do about it? No. Load and go. Transport. Foot on the gas. All right, pulsating masses. We're going to get into that much more in depth in our trauma section as well. But pulsating masses, that's what's called a triple A. A triple A. Your abdominal aortic aneurysm. Your aorta. What is that? What's an aorta? It's a major blood vessel. Yes. Okay. It is your abdominal aorta. Okay. The descending aorta. All right. Aneurysm. What's an aneurysm? It's a weakening of the wall. Okay. So basically, if you guys ever taken a hose and kinked it and then watched a section of it balloon out, that's what's happening with your aorta. So that balloon, okay, that we see is that pulsating mass. Why is it pulsating? Because it has a pulse. Okay, it's your aorta. Is that an artery or a vein? It's an artery. Okay, so it has a pulse to it. Problem or not a problem? Oh my God, huge, huge, huge problem. Those people are probably minutes away from death. I've only seen it one time, and that was when I was in Afghanistan, and the guy looked terrible. They brought me to him. There was nothing I could do. I told him, he needs to go see a doctor. He was not a U.S. soldier. He was a local national. There was nothing I could do, even legally. I said he needs to go see a doctor. They said, okay. This is all with interpreters and everything. I turned around, left, and about 10 minutes later, they came running back to me to tell me that he had fallen, which I took to mean that he collapsed. When I came back, he was already dead. There's not a lot of time with these. These are absolutely load and goes. All right, peritonitis. What is that? Did he talk about this at all? Okay, inflammation, infection of the peritoneum. Okay, that's the lining of your stomach. Okay, the lining of your stomach is called your peritoneum. Or I shouldn't say stomach. When I say stomach, I'm talking about the abdomen. Okay, it's the lining of the abdomen, not the actual organ, the stomach. Okay, so check for signs of peritonitis, okay, inflammation, infection of the peritoneum. All right, so they may have a fever and be complaining of abdominal pain. They may be tender on their abdomen. How do we check? Hand over hand, palpating all four quadrants. We may also do a heel test, okay, where you can either strike the base of their heel or we can have them lift up on their tippy toes and then forcibly slam down on their heels. What are we checking there? Anybody know? No. That is a sign to check for appendicitis. Appendicitis. Okay, so where's your appendix? Where is that? Lower? It's your lower right. All right, have you guys ever heard of the term GLASS? GLASS, here's another acronym to help you remember the organs and where they are in your abdomen. Okay? GLA, okay? Gallbladder, liver, appendix. GLA, that's your right side, GLA. These aren't the only organs in there, but this is gonna help out. Okay? The left side, SS, what do you think that is? Spleen is one of them? Stomach and spleen. Okay, so that's how you can remember it. GLASS, glass. What are some other organs that are in there? Yeah, that's going to be a little further down, our upper, our large and small intestine. Kidneys, okay? Those are more posterior, okay? But also they are still technically within the abdominal cavity. What organ creates insulin? Pancreas. Okay, so those are other organs that are in there, but just remembering some of the major ones: the gallbladder, liver, appendix, stomach, and spleen, because we're going to see a lot of complications with those specifically throughout all of our medical careers. All right, assessing the pelvis. Okay, so opening the book, closing the book. Okay, palpating like that, pushing down on the iliac crest. Okay, and then pushing in, opening the book, closing the book. If there's any instability with the pelvis, what do we immediately do or not do? We immediately stop touching that area. They need what type of stretcher? Scoop stretcher. Why do they need a scoop stretcher? Can I log roll somebody with pelvic instability? Absolutely not. Why not? Oh, I could cut an artery. What artery? Talk to me, boss. You're so close. Femoral artery. Okay. Yeah. Femoral artery. So, you're going to get this in your trauma lecture. Okay. Approximately how much blood, okay, is in the average adult male and female body? Way more than that. We are talking 5 to 6 for males, adult males, 4 to 5 for adult females. This is average. Okay, how much blood do you think can be lost into the femoral cavity, okay, into your legs, just from your femoral artery? How much blood do you think? 1.5 liters per leg, for a total of 3 liters. How much blood do you think, or fluid, period, can go in your abdomen? 10 liters. Theoretically, your entire supply of blood can leak out into your abdomen. Okay, that's not realistic. You'd be long dead because your heart would stop beating at some point and it would just sit in your veins and arteries. But theoretically, you could fill up your entire abdomen twice over. All right. Other things we can do on a secondary assessment. Okay, looking for DVT, deep vein thrombosis. Okay, this is where we're going to be checking the calves. Okay, calves, and see if they have any pain. We see a lot of that. Pain in the back of their calves can be indicative of DVT. All right. If you want to go crazy with it, you can check their dorsiflexion and plantar flexion. Okay. So which way is which? Dorsa, plantar. Exactly. Okay. What is that pulse point called on top of your foot? Dorsalis pedis. Dorsalis pedis. Nailed it. All right. Here we are checking the back of the calf, okay, for possible signs of DVT, assessing the pedal pulses. We just called it what? The dorsalis pedis. Crushing it. What is the pulse point behind behind your ankle and all that? It's your posterior tibial. Posterior meaning front or back? Huh? Posterior, front or back? Back. Tibial. What is that? It's one of the leg bones, right? Is it the big leg bone or the small leg bone? Is it? It's the big one. Okay. You guys ever heard the term FEB? What is a FEB? If you're like a child, a lie. Okay. Think of like a little white lie. Think of the fibula as the little white bone. Okay. It's an easy way to remember it. Tib fib or fibia. I said fibula. Tibia and fibula. God, I'm messing all that up. All right, system PMS. Okay, what does PMS stand for? Pulse motor and sensory. All right, we don't need to get into that. All right, doing the same thing for the upper arm. Check for PMS. Okay, check it for both hands at the same time. What are we checking there? Strength. Strength. Okay. All right, checking for arm drift. What is that? Why would we be looking for arm drift? Stroke, possible strokes. All right, so we also need to check the posterior portion of the body. Oh man, you know what? There was something I forgot to talk about in the neck, and that's also important here. When assessing the spine, you might be checking for step off. What is step off? So if our vertebrae are misaligned, where one or more are jutting outward in like a stairwell pattern, we call that step off. Okay, so we're looking just in the spine when we're checking the neck. When we get to the back, we need to check the entirety of the spine for step off. Okay, checking the entirety of the spine. When we get down to the buttocks and the lower extremities, what are we looking there? Specifically the buttocks. What are we checking for during our secondary assessment? Say what? Okay, maybe the tailbone is broken. Probably not going to be very easy to see. All right, but that's a possibility that there's tenderness right there. At the let's talk about the different vertebrae real quick. So we have the cervical spine. What's next? Thoracic. Then the lumbar. And then we have two more. Sacral and the coccyx. All right, so that coccyx, that tailbone could be broken. Yes, that's a possibility. But what's something we might be able to see a little bit more clearly, or maybe smell while we're down there? Defecation. We might see blood, urine, or defecation down there. Okay, some buds. Blood, urine, and defecation. So that's a possibility. Let's say that they were involved in a motor vehicle accident, and we're doing our assessment. We do head to toe. And then we check their posterior portion, and they're completely unconscious, unresponsive, and they have clearly soiled their pants. What might have happened? Say what? It could be. You said what? It could be brain damage. Could be spinal damage. Okay, that they can no longer hold their bowel or bladder. Okay. So that's something you need to take into consideration when you're doing your assessment. Because if they're unresponsive, are you going to know if they do or do not have sensation in their lower extremities? Probably not. Not easily, anyway. All right. Performing the assessment, we check on all these conditions and its body systems. All right. Chest shape and symmetry. We already discussed this when we're palpating. Checking their blood pressure, peripheral and central pulses. All right. Checking the neurological system. If possible, Okay. We'll get more into this in a little bit. When we talk about neurological, actually, let's go for it now. Facial expression, speech, and all that kind of stuff. If they have facial droopage and slurred speech, what might that be a sign of? Stroke. Might be a sign of a stroke. All right, posture, motor activity. You might have people with a severe shake. What might that condition be? Starts with a P. Parkinson's. Okay, they might have Parkinson's. Musculoskeletal problems. Okay, we talked about all this when we're palpating, checking for decap BTLS. And in addition to decap BTLS, we're going to check for instability and crepitus. Okay, we talked about pelvic instability. What is crepitus? Anybody ever heard that term? It's in your book. Crepitus is that bone on bone grinding. So when you are palpating, okay, you're getting your hands on your patient. If you feel that bone on bone grinding, that's called crepitus. All right, vital signs. Let's talk about them all real quick. We know that we need heart rate, respiratory rate, SpO2, and blood pressure. What are some other very important vital signs? We talk about heart rate, respiratory rate, blood pressure, and SpO2. What else? Temperature, huge. There we go. Our BGL, blood glucose level, okay? We need to check their blood sugar. If it's too low, what do we call that? Hypoglycemic. If it's too high, what do we call that? Hyper. What's the normal range? 80 to 120. 80 to 120. Okay, but there's caveats to that because if they just ate, okay, that's going to be important, or drank something. What's the normal rate for an adult respiratory rate? 12 to 20. With a star, what's that star? Unlabored. Unlabored. What do we say is a normal blood pressure? 120 over 80. Systolic is the top number or bottom number? Top. What's the bottom number called? Diastolic. Okay. Pulse, heart rate. What's a normal rate for an adult? 60 to 100. If it is below 60, what do we call that? Bradycardic. It's faster. Tachycardic. You remember for respirations, slow is bradypnea and tachypnea. Know those terms, guys. You're going to see them on your exams. All right, speaking of terms, here's that sample that we were talking about earlier, signs and symptoms. What's the difference between a sign and a symptom? A sign is something I can see or quantify, okay, like blood pressure. I can quantify the blood pressure through tests and exams. Give me an example of a symptom. My neck hurts. I have a headache. Okay? Those are symptoms. That's what my patient is telling me. Allergies. Allergies to what? Medications. What else? Food. What else? Latex. What else? Zip. Insects, animals and insects, okay? And somebody else nailed it. They said pollen. Environment, your environmental allergies. Okay, medications. What type of medications? Prescribed? Over the counter? Over the counter? Well, when you say self-medicate, what are we talking about? Who said that? Oh, there we go. Drugs, alcohol. Drugs, alcohol. Illicit substances. Okay, what else? So when we think of medications, we're just thinking about prescribed meds. No, it's all this, okay? We're going a little bit further than okay. Well, those are prescribed or over the counter. But those are important. Those are important, and we're going to talk about why they're important in just a minute. Okay, you're talking about like erectile dysfunction drugs, right? Yeah.
Like Viagra or stuff like that.
Yes, those are erectile dysfunction drugs. Cinefil, I think it's called, is the other name for it. We're going to talk about those. Super important. You guys are giggling, but it's very important questions to ask your patients. All right, so we talked about prescribed over the counter and then drugs, alcohol, illicit substances. What else? I'm European, so I say it a little weird. Vitamins, okay? Vitamins, all right? It's important to ask about that, okay? What else? Gym bros, what are they ingesting? Okay, possible steroids, which are illicit substances, but what else? Supplements. What do a lot of those supplements do to your heart? Make it beat much faster. Bless you. So, bless you. So if I'm called out to crunch for somebody that collapsed, okay, what's one question I'm going to ask that person if they're alert and oriented? Are you taking any pre-workout? Are you on any supplements? Because if I say, are you taking any medications? They're probably going to say, no, I'm not on anything. But I need to go further. I need to ask, are you on any pre-workout? Are you on any supplements? And another good point, he mentioned steroids. Are you on any illegal or illicit substances? So we think a lot of times about drugs. Are they on meth, crack, heroin, stuff like that? But we also got to ask those kind of questions. Context important. If I'm at the gym, my guy's probably not shooting up PCP in the bathroom, but he might be doing steroids. All right. Past medical history, pertinent past medical history. Okay, if I'm there for someone that is having chest pain and they're an elderly gentleman, and I say, hey, sir, can you give me your medical history? What do you think he's going to say? Well, in 1935, I fell over an oak tree and twisted my ankle. Sir, I do not care. Okay, I do not care. What's going on with your condition now? Have you been to the doctor for this before? Okay, stuff like that. Last oral intake. Hey, when was the last time they ate or drank anything? L also has another term for it. What is another L that I need to ask? This is important and pertinent for women of childbearing age. When was your last menstrual period? When was your last menstrual period? Okay, why is that important? Because it could be pregnant, which can affect what? Everything. The medications I give them, okay, that can be very important because medications have classes that include pregnancy. All right, so last menstrual period. And E, events leading up to the event or events leading up to the injury or illness, which leads us into onset, which is the exact same thing. Onset, what were you doing when it happened? What were the events leading up to the injury or illness? Provocation, palliation, what does that mean? What makes it better or worse? Okay, provocation, worse. Palliation, better. What makes it better or worse? But we just say provocation, palliation. You guys have heard of palliative care? Hey, what is that? End of life care. Okay? So you're just trying to make things comfortable for them. What makes it better or worse? Quality, what is quality? Can you describe the pain? Who's describing the pain? The patient. What do we not do? Don't give them suggestions. Here's an example. Someone has chest pain. I'm not going to say, sir, is your pain sharp or dull? Because what do you think they're going to tell me? Yeah, it's kind of sharp and dull. Come on, guy. Is it sharp or dull? Which one? Radiation. Also region. Okay, so with one finger, can you point to where the pain is? All right, so if they're right here, that's the region. And then radiation is what? Does the pain go anywhere else? Okay, so let's say they say the pain is right here in the middle of my chest. Okay, what's the next question? Does it go anywhere else? Yeah, I have this shooting pain down my arm as well. What might be going on with that person? Heart attack. Okay, that's like the classic signs for a man having a heart attack. Pain in their chest and, bless you, shooting down there. Which arm? Left arm. Why the left arm? Heart's on the left side. Women, how do you think they kind of react to heart attacks? The same? Different? Very different. Okay? They typically complain of abdominal pain or back pain. One call I went on, this is like 2 years, no, about a year ago now. It was a woman at a country club. She thought she was just having some indigestion. When we got there, she's just lying on the floor, kind of just lackadaisically. Asked her what's going on. Honestly, I didn't take it very seriously, which I should have. She just said, "Oh, I'm just having a little bit of a, stomach pain." We got her in the back of the truck, put the 12 lead on. What do you think I saw on the monitor? Massive heart attack. She was having a massive heart attack. No outward signs or symptoms of it other than just a little bit of stomach pain. Okay, so that's a two-part thing. Women react very differently to heart attacks and always treat every call as if it is the most important thing in the world, because that person might be literally dying. Severity. What's severity? The pain scale. Pain on the 1 to 10. T, when did this happen? So that's different than onset. How is it different? Yeah, onset is what were you doing when it happened. Time is when did it happen. Okay? All right, so physical exam, vital signs, and history. We just covered all that. History, that sample OPQRST. All right, talking about MOIs. These are just some examples. Read them in your book about some moderate risk. Okay, moderate risk. All right, here's some significant ones. Rollover. Why is a rollover such a significant MOI? Because there's no way of knowing what they struck or what struck them. There's so many different possible angles. Okay, here's another one. You might see this on the test. Okay, intrusion. Intrusion of greater than how many inches? 12 on the passenger side or anywhere at 18 inches. You might see that on the test. All right, so something like this. C-collar? 100%. Consider ALS. What's ALS stand for? Advanced Life Support. Who is that? Paramedics. Exactly. And we're going to reconsider a transport decision. Load and go or stay and play? Load and go? Yeah, definitely. Load and go. AVPU. What's AVPU stand for again? Alert, verbal, painful, unresponsive. Okay, orientation to time, place, person. Okay, or the A and O. That means are they alert and oriented? Just because they're alert doesn't mean they're oriented. Okay, they may be having a conversation with you, but think it's 1945 and they're in the middle of France. All right, and the Glasgow Coma Scale, which we saw earlier. Flexion and extension. So this one, extension, it's right here, decerebrate. What is flexion? What do we call it? The other one's decerebrate. Decorticate posturing. Decorticate posturing. Here it is. You see it. A normal flexion is called decorticate. Extension is decerebrate. What did we say extension was? When their hands and arms start to curl outwards and they start to look up and away. Toes splaying outwards. Decorticate coming into the core, toes inwards. All right, still on this, that inspect, palpate, and auscultate. Okay, I don't think this is the right order. Okay, should be look, listen, feel. Okay, when we're doing anything, look, listen, and feel. Look, listen, and feel. Let's say you had an abdominal patient. Okay, you look at their stomach, then you're gonna auscultate with your stethoscope, making sure they have abdominal sounds. What might I hear with the abdomen? What am I going to hear? In the abdomen. Gurgling, right? Gurgling. Anybody ever have their stomach growl? Hey, loud as hell? All right. Now it's that, but just on a much softer scale. Why do you think I need to listen before I start palpating their abdomen? Because when I palpate their abdomen, I'm going to excite their abdomen, and then it's going to be very gurgly, basically no matter what. So I'm going to listen first in that order. Look, listen, feel. Look, listen, feel. Common signs of trauma. All right, deformities. Okay, obvious deformities, contusion. Contusion is another name for what? Bruising. All right, real quick. Hematoma. What is the definition of a hematoma? Hema meaning what? Blood. Okay, is a collection of blood under the skin. That's different from a bruise. Different from a bruise. You might also see the term ecchymosis, which is discoloration of the skin. Abrasion. What's another name for abrasion? Road rash. Like scraping your knee. That's an abrasion. Punctures, penetrations. Burns. How many categories of burns are there? 4. 4. First degree burn is what? A sunburn. Okay, yeah, the outer layer of skin, which is your epidermis, someone just said. What's the difference between a first and second degree burn? Say what? What do we call those bubbles? Blisters. The difference between first and second degree burns is blistering. What is third degree? That is in all 3 layers of the skin. Okay? And lastly, that 4th degree, that's not really talked about very often, is pretty common with electrical burns or severe thermal burns. If the patient's been lying there for a while, that's burned all the way down to the bone. We have charring of the bone. All right, tenderness. Tenderness, is this a sign or a symptom? Maybe. So you're saying a symptom. Why are you saying a symptom?
Because you can't tell the tender until they react to it.
Yeah, the patient's going to say, oh, that hurts. It's kind of both, but more of a symptom than a sign. Okay? So it's in that gray area because I might push on their abdomen and maybe they kind of grimace, a facial facial response. Okay, but are they definitely grimacing because I'm pushing on the abdomen? I could say pretty certain, but I can't 100% know. So it's in that weird sign and symptom area. So we're in the PEC12. What is that? Laceration? What is that? What do we call a laceration? Just a cut, okay? Just a cut in the skin. And S is swelling. All right, checking out the head. Okay, we talked about this before. We're assessing for altered mental status. Okay, equal or unequal pupils. That pearl, what do we call, what does pearl stand for again? Equal, round, reacted to light. Okay, real quick, if they are unequal, if I have one that is blown out and one that is constricted, what do I think is going on with that patient? Head injury, significant head injuries. Do you guys have something for me?
No, not for you.
Okay, fine. All right, CSF. How do we check for CSF? What's that test called? The Angels. What's it called? Halo test. Okay, look in the mouth for blood, secretions, vomit, all that stuff. Unstable findings in the head, we talked about this. Rapid trauma assessment, okay, boom, boom, boom. We talked about that. In the neck, jugular vein distension or tracheal tugging, okay, or deviation. Any suspected spinal injury, they need a cervical collar. All right, we're going to talk more about JVD and tracheal deviation in our trauma sections. Okay, I suggest going through your book and kind of looking through these a little bit more significantly. Here's where we're inspecting JVD. Here's a good photo of JVD, jugular vein distension. What is this guy checking for? What do we call that? Step off. Step off. Step off. All right, we see step off, immediately put a C-collar on. All right, of the chest, open wound, paradoxical movement. So I didn't explain what that was, but I talked about it briefly. So a flailed chest, paradoxical movement and a flailed chest. When we take a breath, what does our chest do? It expands. When we exhale, what does our chest do? Contracts. In paradoxical movement, we have that flailed segment, okay? We have two or more ribs right next to each other, broken in two or more places, okay, along the same rib. And what happens is when we inhale and our chest expands, that section will sink in. It'll sink in. And when we exhale, what do you think that section is going to do? It's going to push out. Paradoxical motion. All right? Absent or decreased breath sounds, that might be because of tension pneumothorax, which we're going to discuss later. Poor chest wall movement could be from a lot of different things. It could be just bruising of the lungs, okay, or bruising of that tissue around the chest, okay, broken ribs. There are a lot of reasons why they might have poor chest wall movement. So we palpate, palpate, palpate. All right, here's something. What would you do for this? Pack the wound. Can we put a tourniquet on this? The arm, maybe there's enough room, but probably not. Okay, that'd be very, very close to the site right there. It may not be good, a good site. So we're gonna have to pack these wounds, especially this one that's on the trunk. Okay, we call these axillary wounds. This is your axillary area because we can't do much about this. Can we put a tourniquet over here that's closer to their chest? No, there's nothing we can do for that. Okay? So we're going to have to pack that wound. All right, here, it's the same injury, same guy. What's going on there? A broken bone, what do we call that? We're medics now, or we're EMTs now. What do we call that? A fracture. Okay, when we also take the chest, apex, apex, base, base. Get the abdomen, looking for tenderness, rigidity, distension, bless you, or what else? Starts with a P. Pulsating masses. All right, if we see protruding organs, okay, what do we call that? What do we call that when there's organs spilling out? Starts with an E. Evisceration. You ever heard that term before? Evisceration, abdominal evisceration. That's where organs are spilling out. So, I don't know if it's on this test or not. Maybe it's probably in trauma, but just FYI. If you do see any abdominal evisceration, those organs, just put them back, just set them back on top of the abdomen and put a wet dressing on top of it. Why a wet dressing? You don't want them to dry out. What happens if those organs dry out? They die. They die. And they are very important to your life. Okay? So you want to keep those organs very wet. And then you put a plastic dressing over it. Occlusive dressing. Occlusive dressing. All right. More, like I said, read these in your books. I'm not going to go too in depth. Checking for tenderness, rigidity, and distension and pulsating masses. Okay, assessing the pelvis. What do we do? Open the book, close the book. What happens if we see any or feel any instability? Stop. Immediately stop. Why? Because what artery? Femoral artery. Exactly. They need what type of scoop? Oh, damn it. I just said it. Oh, I just swore. This is supposed to be recorded. You didn't hear that. I'm going to have to edit that out. Okay. They need a scoop stretcher. They need a scoop stretcher because we can't do what with them? We can't log roll them. All right, here we're inspecting the lower extremities. Okay, we're checking for instability and crepitus. What did I say crepitus was? Bless you. Bone on bone grinding. Okay, as kids, okay, we're mostly men in this classroom. You guys ever take a brick, two bricks, scrape them together like weirdos? Because it's what weird kids do. All right, that's what it feels like. That's what that feels like, that bone on bone grinding. What's this pulse point called? Dorsalis pedis. What's the other one back behind the ankle called? Posterior tibial. Nailed it. Tibia, big or small? Big. Little one's the, what? FEB. All right, tip FEB. There we go. What is he checking here? PMS. Okay, pulse motor and sensory. A couple semesters ago, this is actually about, like a couple years ago, I had a student that was offended by PMS, so I had to switch it up to CSM, sensory, circulation, sensory, motor. It's ridiculous. All right. Palpating the upper extremity, same thing, checking for tenderness, instability, and crepitus. Checking the pulse. We should check them both at the same time. Why? Make sure that they are equal. Okay, present and equal. And the chest. All right. So this is posterior. Posterior is what? Front or back? Back. Say we're checking for any open wounds. Okay, and we close those wounds up if we have to. All right. Unstable patients. How often do we assess vital signs on unstable patients? Every 5 minutes. Stable patients, every how many minutes? 15. All right, so these are some examples of critical findings and vital signs for unstable patients. Okay, absent carotid pulse, obviously, is a pretty big sign because that means that there's no blood going to what? If I don't have a carotid pulse, no blood is getting to what organ? My brain. SpO2 of less than 93% is a critical finding. Okay, there are special considerations. Sometimes we might have patients that it is normal for them to have an SpO2 of less than 94%. Can anybody think of a group of patients that would be normal for less than 94%? They might be elderly. No. If you smoke for a long time, what condition might you develop? COPD. COPD. Emphysema patients typically have SpO2s of less than 94%. That's normal for them. Okay, unequal pupils. Okay, cool clammy skin. What did we say that was a sign of? Shock. All right, sign of shock. Cool clammy skin. Here we are checking the SpO2. We also want to check for the glucose. What did we say was normal for them? On average, what's normal? 80 to 120. And again, asterisks there, 80 to 120 asterisks because everybody's different, okay? And they might be on medication that affects that, and we don't know when they last ate or what they ate. That's why it's important that we ask the L in sample, which stands for what? Last oral intake. Good job. Here we are reading that. Here's sample. Okay, we just covered that again. Trauma patients. Yeah, these are high risk or serious injuries. Okay, moderate. We talked about these before. Some of these injuries we're going to get more in depth on our trauma sections. Okay, not going to beat up this too much because we're going to talk about that in trauma. Okay, here are some abbreviations that are important to know. MI stands for what? No, sir, that's MOI. MI stands for myocardial infarction. What does that mean? What is a myocardial infarction? A heart attack. An MI is another term for a heart attack. COPD, what does that stand for? Chronic obstructive pulmonary disorder. Chronic obstructive pulmonary disorder, also called disease. Sometimes it's a disorder. CHF, what's that? Congestive heart failure. So close. So close. All right. Know those. You're going to see those on exams. All right. Life-threatening emergency. What do? Treat and transport. Okay, quickly. Here's the Glasgow Coma Scale, okay, or excuse me, the revised trauma score with the GCS. You don't need to know this for your exam, but on your NREMT, you might get questions about like the Glasgow Coma Scale. You also might get questions about like the like with strokes. You might get asked questions about other types of scales, which I think is unfair, but that is just how it is. All right, so a trauma patient with no significant MOI. So they are stable, no significant MOI. How often are you checking vitals on this guy? Every 15. Okay, because he's what? Stable. There you go, because he's stable. Medical patient who is not alert, disoriented, or unresponsive. Okay, we can ask them a lot of questions. Unequal pupils, ultimate mental status, facial droop. What we say facial droop might be a sign of? Stroke, especially if accompanied by slurred speech and arm drift. Okay, so here we are palpating the head, checking for, it's the same thing over and over again, guys. Okay, this is just a medical patient. We're still doing the same thing. Checking for JVD, checking for tugging. Looking for alert bracelets. What might alert bracelets be able to tell us? Past medical history and allergies and medications. Huge, huge source of information there. All right, talking about the chest. When we're auscultating, you might hear these types of lung sounds. Wheezing, upper or lower airway obstruction. Lower. Wheezing is a lower airway obstruction. It might be a test question later. Crackles, upper or lower airway obstruction. Or complication. Lower. Crackles is also lower. So crackles is also called rales, R-A-L-E-S. It's also called rales. So what that is when you're auscultating, okay, especially in the bass, but you might hear it in all four quadrants, it's when you hear little pops, little pop, 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 pop. And what that is, those grape-like, what are those grape-like sacs called in our lungs? I've heard a lot of wild stuff. Somebody just said areolas. That is not correct. It is alveoli. Alveoli, okay? Those are those grape-like sacs where gas exchange occurs. What is that gas exchange that occurs? Which two gases? Oxygen and CO2, which is carbon dioxide. Okay, so crackles, also known as rales, that popping open of the alveoli, that is them, they're typically surrounded by fluid. So when you take a deep breath, on